Hi guys, welcome back. The next topic we're going to study is bundle branch block. I shall be explaining to you the ECG criteria of left versus right bundle branch block, but we first need to understand what's going wrong here. You see, in a normal individual, the left and the right ventricle will contract at the same time. But in these patients, we do not have a simultaneous contraction, but we have is a sequential contraction of the ventricles. And you may ask, what's the big deal about it? Well, the big deal is, let us assume a patient is having left bundle branch block. That means the left fascicle or bundle of his is damaged. So the impulse conduction to the left or the timing of the left is wrong. What I mean by timing wrong is contraction of the left ventricle is not going to occur at the right time. Now, when the right ventricle will contract, obviously the blood will go into the lungs, but because the left did not do its job, therefore there would be pooling of blood in the lungs contributing to a severe pulmonary edema and patient can even die. Guys, I want to tell you that myocardial infarction can actually result in left bundle branch block, and LBB, left bundle branch block, is one of the diagnostic criteria. When you read the definition of MI, you will read about chest pain, ECG criteria, biomarker criteria, but along with that, I'm adding or supplementing a new onset left bundle branch block is also a diagnostic criteria, and this can really be lethal and can contribute to death due to what I explained. The right has done its job, the blood has gone into the lungs, there would be severe pulmonary edema due to pooling of blood in the lungs of this person. And well, right bundle branch block will also cause problems for the patient, but lots of time right bundle branch block can be physiologically present as well. Left is always pathological, right can be physiological, though I'm going to talk about other causes beyond physiological for right bundle branch block as we progress. At the moment, there are two messages that I've given you. One is, whenever you read in a question new onset left bundle branch block, you should always consider the possibility of myocardial infarction in a patient. And I also explained why we are worried about the patient, because it's not going to be a simultaneous, it's going to be a sequential firing of the ventricles. Now, for us to understand the ECG criteria, we will first focus on a normal ECG, and then I'll explain to you how to progress for the criteria for bundle branch block. Whenever you are given a ECG in the exam, the first and the foremost thing to be done is look at the heart rate, calculate the heart rate. And how do you do that? You will be basically counting the RR interval. The formula is 300 divided by the RR interval. Let's count the number of squares here, that there are 4 large squares. While I'm writing it, I want to highlight that the only time I'm asking you to count large squares in the ECG is for the heart rate. Everything else is going to be the small squares. In this particular case, the heart rate is turning out to be 75 beats per minute. So now we will calculate the axis. For calculating the axis, what you need to do is look at the two leads, lead number 1 and lead number AVF. Now in the exam, you're not going to have this luxury, but here I'm just going to draw a graph like this. On the x-axis, I have plotted 1. On y-axis, I plotted AVF. And now we're ready to do something that we do in class 10th, that is vectorial analysis. If you look at the height of the R wave in lead number 1 as compared to S, I mean S is almost non-existent or hardly seen. So I can say that the vector of R minus S will be positive. Similarly, when you look at lead number AVF, again R is substantially big, S is almost non-existent. So my final interpretation is that the vector of lead 1 is also positive and AVF is also positive. So I'm just going to plot it here. And when I plot it here, I'm just gonna draw a vector here which is falling in the quadrant that is currently highlighted, and that's gonna be normal axis. So first message in this question per se, or this ECG if given to me, is that person is having a heart rate of 75 beat per minute along with normal axis. And now we will focus on P wave, height and duration, and you need to see whether every P is followed by a QRS or not, because I want to identify normal sinus rhythm, or is there going to be drought beats present in a person, is it an irregular rhythm. So let's check. When I zoom in here, you definitely can notice the configuration of the P wave. The duration of the P wave looks to be approximately 2.5 small squares. I've told you normally the duration of P wave should be less than 120 millisecond, and the duration looks fine. Now let's look at the height also. Height is almost about 1.5 to 2 small squares. So what I can definitely say is height and the duration of the P wave per se in this condition is normal. After that, I'll also scan the PR interval in this patient. So I'll just use a different color to highlight it. The PR interval in this case also looks to be pretty decent. It's a little in the range of about 3 to 4 small squares. I've told you normal is about 3 to 5. That would be approximately 120 to 200 milliseconds. Since the PR interval is also fine, I'm now also seeing the fact that every time there's a QRS complex also occurring, that means that the conduction of waves is occurring properly. So the next word that I'm going to write after normal axis would be that the patient is having a normal sinus rhythm. P wave configuration is okay, PR configuration is okay. Let's look at the duration of the QRS complex. You will notice that the QRS is approximately 2 small squares, that's 80 milliseconds. So even the QRS duration is normal. After that, I will focus on the ST segment. For that, I'll obviously look at the entire ECG, not only the limb leads per se. So if you look at the limb leads in this particular recording, you will notice that per se there's no significant segment changes. There's neither a ST elevation, neither a ST segment depression. I also want to tell you that it is important that you always check out the Q wave, especially with respect to bundle branch block. I'll explain the reason why, but where should you check the Q waves in the ECG? So the site where it is recommended to check for Q waves is V5, V6. I'll give you the reason for that also, but you can definitely see a small negative deflection before the R wave in the patient, that is the Q wave. Well, the reason for this is septal activation, guys. You know, if I just represent it here, and it has been represented earlier also, if this is bundle of phase, this is the left fascicle, this is the right fascicle, the vector points like this. What I mean by the vector pointing like this from left to right is that septal activation proceeds from left to right, and the electrodes which are going to be reading this current, this blue arrow that I've drawn, is actually the septal activation. This is representative of Q wave. You can see that the current, the blue vector is going away from V5, V6. Because it is going away, that is why it's a negative deflection. So there's no point of you trying to waste your time and trying to check for the Q wave in V1, V2, because it is hardly visible. The site where you are supposed to check for the Q wave is V5, V6. And why are you supposed to check it, especially for bundle branch blockage, will become obvious as I progress in the discussion subsequently. But in this particular case, I can say that this is a perfectly normal ECG. Another thing that you will also notice per se, though I can mark on the ECG, I'll try to hand draw it. In lead number 1, in a normal person, the height of the R is always lesser as compared to that of S. As you move to lead number V3, the height of R and S will become almost equal. And as you progress towards, let me say, V5, V6, then the height of the R will be more than that of S. I repeat what I said. I said in you and me, in lead number 1, R wave will be shorter, but then the height of the R wave will definitely keep on increasing, and we call this the progression of the R wave. But you will notice that in the all ECGs of bundle branch block, this normal progression of the R wave will definitely be hampered. Once you have a hang of identifying these baseline parameters, we will now look at what is the problem for my patient. I want to highlight that in a normal person, the current goes from SA node, AV node, bundle of phase. First current goes to left ventricle, that is via the left fascicle, then to the right. Why? Because the refractory period of the right fascicle is relatively higher. I have explained this in hard sounds, guys. Why S1 is called as M1T1 is because current will first go to the left side, so mitral valve will close, then tricuspid valve will close. So the basic message is the refractoriness of the right fascicle is relatively more. This is what happens in us. And I've also shown the arrow of septal activation, which is going to be responsible for Q wave in a normal person. Now, if I draw cardiac muscle around it, let me say this is the cardiac muscle, and that if I draw the electrodes, you can see that the current of septal activation is literally going parallel to V1, V2, but it is going away when it comes to lead number V5, V6, and since the current is going away, therefore Q wave is a negative wave. This is again what I have represented is perfectly normal. These are the Purkinje fibers through which there would be a flow of impulses, and the current will flow from inside to outside, and therefore there would be a ventricular depolarization. The problem in a patient who's suffering from left bundle branch block will be that first you focus on the word block. Block implies that conduction will be relatively slower, and therefore there can be a broad QRS. The reason why you get a broad QRS in bundle branch block, one can be understood from the English word block, or I can say if the current is not going to be able to travel across the left fascicle, it will then travel via the muscles. The conduction speed via the muscles is lesser than that of the Purkinje. Remember, I've taught you Purkinje is the fastest conducting fiber in this left bundle branch block patient, because the current is not going to be able to flow normally. The conduction system itself damaged. It will utilize the muscles per se to travel, and therefore intermyocyte conduction is present in these patients. That again explains intermyocyte conduction is slower than the conduction in the fibers per se of the, because conduction system is designed for conduction. Muscles are mainly designed for contraction. contraction. If you are going to be using the area that is muscle which is supposed to do contraction for you is going to be utilized for conduction, then optimal results will not be obtained. So bundle branch block will always be having a broad QRS. That's one of the important parameters that I wanted to remember. The second point is that now, because the current will definitely be able to go across the right side, no problems, but will be able to reach onto the left side with a delay. So we also notice that the direction of septal activation changes in left bundle branch block. The vector will change. Because of this change of vector, guys, the Q wave in the ECG will not be seen. Remember, Q wave is a negative wave. The vector points from left to right, but in left bundle branch block, because the vector is pointing the other way around, so that will definitely contribute to positivity. This current will definitely contribute to positivity in the upswing towards the R wave, definitely, because next thing I'm going to say is tall R waves. But the point is, you will not be able to identify Q waves in a ECG of left bundle branch block, and that is something which is very minor. You might say, sir, Q wave is such a small wave and you are expecting us to pick it up in the exam in a pressure cooker situation that it is absent. I mean, that is not something which from a student's perspective is very attractive, because a student would definitely want a faster way to analyze the data. So the faster way, guys, is that if I draw the cardiac muscles here, that is in the surrounding area, that's the cardiac muscle that I've highlighted now, and you can see that the current that is shown going from right to left, that will add up to the R wave in lead number V5 V6. So one of the important criteria that you will always notice will be tall and broad R waves. I'll show a image of this also subsequently, guys, but at the moment we are focusing on the theory part. So the point is that definitely the current will flow to left side. Definitely in V5 V6 there's gonna be R, but it's gonna be relatively taller. Why? Because this current is added, whereas in a normal person it's a negative current. Then reason for broad is what I again highlighted, that's gonna be intramyocyte conduction present in a patient. And lots of time, especially in lead number V5 V6, you will also notice another very interesting thing, which can be that in this tall and a broad R, the upper part of this can be having a M pattern. This M pattern is basically signifying a sequential contraction of the ventricles. It is highlighting the fact that both of the ventricles are not contracting simultaneously. This rabbit ear appearance or a M pattern, I repeat once again, this rabbit ear appearance slash a M pattern may not be visualized in a ECG that we commonly see in a government hospital, because you see it is so misused that the ink blots on the paper, the quality of the paper is bad. So don't rely on especially this M pattern that I'm saying, rabbit ear appearance. This is one of the features in the textbook, may not be visualized. You need to focus on very tall broad waves present in this patient. And the next thing would be that because this current is going away, you can see the current that I've highlighted with a dotted fashion around the area where the left bundle branch damage is present. Therefore this current which is going away will also contribute to a relatively deep and a broad S. Now we do get a S wave in lead number V1, but this is going to be relatively a deep and a broad S. And if it's a good quality ECG, again, in the downswing of the S, when it's going to end, you might again notice that notching, that is rabbit ear appearance or a M pattern present. The bottom line with respect to left bundle branch block would be point number 1, broad QRS. That's going to be present even in right bundle branch block. But the special features are absence of Q, presence of tall broad R waves in V5, V6, and a deep S in lead number V1. I'll also tell you a hack or a shortcut how to remember it, but now I'm going to tell you something very, very interesting with respect to ECG, especially of left bundle branch block, that I will show in the actual ECG per se. You will always notice, as I highlighted, presence of deep and broad S waves in lead number V1, V2. You can see how deep and broad deep S wave per se is present. Now you will notice that whenever you are evaluating the ECG of a left bundle branch block patient, there will also be ST segment changes. And the surprising thing about these ST segment changes, why those ST segment changes come, is because again depolarization of the heart is defective, so repolarization abnormalities will also be seen. We will always find that in any person who's having this left bundle branch block where the S is relatively deep, ST segment will be relatively going up. I have currently highlighted a magnitude of ST elevation. You need to remember that the ST changes that occur in bundle branch block are opposite. That's the word. The ST segment changes that occur in bundle branch block are actually opposite to the predominant vector in the lead per se. Like in lead number V1 and V2, S per se is negative. That's negative vector. So there's a ST elevation that has been documented here in both lead number V1, V2. Let's progress further. you will notice that when it comes to the same patient, as you progress towards lead number V5, V6, you definitely in this patient, I'll use a different color, even notice a bit of rabbit ear appearance coming up, right? That's what I have highlighted. And then you are also noticing a broad S wave. You can notice a broad S wave. So what is happening is that in V5, V6, there is a positive vector. Because of this positive vector, guys, there will be some magnitude of ST segment depression coming up. I'll repeat that again in lead number V6 also. I said the predominant vector in this case, you can see R is bigger than S, no? So that is why the predominant vector in this patient is going to be positive. And because of this, there's going to be some magnitude of ST segment depression that I've highlighted in both the situations. Guys, why I am being vocal about this is because normally I'm going to teach you a condition in which either there is going to be ST elevation in the ECG or ST depression. This is the only ECG where ST elevation and ST depression is present in the same strip. I repeat the fact once again. Guys, please appreciate, normally when you see a ECG, like for example in myocardial infarction, either there's going to be ST elevation or there's going to be ST depression. No, it's not that in few leads ST elevations, few leads ST depression. In bundle branch block, this is actually the only example where in a single ECG, you can see both ST elevation as well as ST depression, which I marked out in red before you. You will notice that in V1, V2, the predominant vector is negative. So ST elevation. And when it comes to predominant vector in V5, V6, it is positive. So ST depression present. This is the only example I highlight once again where you will read in the question ST elevation and ST depression in the same ECG strip. The technical term that is used for this is called as discordant ST segment changes. Now, had I just written this statement, no, discordant ST segment change, it usually does not make sense, but I've tried to explain this to you, and the reason for this is because there's a defective depolarization, there would be a defective repolarization also occurring in the patient. Let's focus on this ECG, guys, and evaluate what's going on. So as I highlighted, we will first be checking the heart rate of the patient. Though there's a slight fluctuation in the heart rate, let me just use this opportunity to mention regarding what am I getting at the moment. The RR interval of this patient would be 300 divided by 5. So the heart rate is turning out to be approximately 60. And then there's a slight variation in the heart rate as we're moving subsequently because bundle branch block can contribute to that. I will now be focusing on the axis of this person. So this is lead 1. This is lead number AVF. Let's see what's going on. In lead number 1, R is definitely positive, hardly any S is seen. So the result of lead number 1 vector analysis R minus S will be positive. I've just plotted that also. But when I look at the data of AVF, look at this, I'll just zoom it in for you. You will notice that the depth of the S is relatively more than the height of the R. Therefore, since the vector in this case R minus S will turn out to be negative, the word is negative, I'm going to plot this negative here. And when I plot it, you will notice that the axis now is coming in a different quadrant. This was the area where normal axis is present. If you move a little laterally, this would be right axis deviation. But in our case, the current ECG, the patient is having a left axis deviation. So two interpretations in this case, the heart rate of the patient is varying. The heart rate is varying something in the range of about 60 to 100. There's definitely a ST segment depression present. There's predominant, I said predominant broad S waves present in lead number V1 and V2, which normally does not happen. And you can also see the progression is not occurring. Now, like I told you that S wave is going to be deeper in V1, V2, and then gradually the height of subsequent waves will change. So the progression pattern is not exactly the same. And most importantly, discordant ST segment changes also came up. Now, because a lot of students say, sir, we find difficult to remember all this, so I'm trying to give you a hack here. That's a mnemonic that you can use to remember findings of left bundle branch block. That is called as William. In William, you need to remember W alphabet is the first alphabet here. So for V1 and V2, you just need to remember that there would be a deep and a broad S wave. If he's gonna be kind on you, there will definitely be a rabbit ear appearance given. Like in this particular case, yeah, a bit of rabbit ear appearance is well noticed in lead number V5, V6. When it comes to V5, V6, you look at alphabet M. It is W and a M coming up. So there's going to be a broad and a tall R wave and then definitely a rabbit ear appearance. So if you just get the first and the last alphabet right of this word William, you definitely will be able to get the facts right. I mean, that's just a small hack that can help you in cracking the question. The most important thing about identifying bundle branch block would be that don't go for rather absent Q waves. Though I told you in the beginning, because that is how it is given in the textbook. I mean, absent Q wave is something that is difficult to appreciate because Q itself is very small. So we will look at the gross changes which are present here, and over and above this, wherever you will look, guys, you will always notice that the person is also having a broad QRS. I have said this in the end because when I say the word block, not that I'm talking about any bradyarrhythmia, I'm just saying whenever you focus on the English word block, it basically means slowness. And the slowness is what is reflected in the ECG. So all the features that I've highlighted earlier are well documented. Let's just quickly recall the findings that are seen with respect to bundle branch block of the left side, and it is one of the important diagnostic criteria for acute myocardial infarction as well. The findings are broad QRS, intramyocyte conduction will contribute to the slowness. Instead of a simultaneous contraction, a sequential firing of the ventricles, absent Q waves, tall rather broad R waves in V5, V6, and rather the same words being used. That is, instead of tall, I'm saying, because it is negative, so I'm saying it is going to be deep, broad S waves when it comes to lead number V1 and V2 in the patient. You can actually take either a picture of this, or I would suggest you to just note down the points that I've highlighted, and once you will practice this once or twice by yourself, then it will become second nature to you, because once you see a case, then obviously it becomes interesting. Okay, I'm going to try and find out what is really going with the heart of this guy. And as I highlighted, a lot of these patients may actually not reach the hospital. They might actually die because left bundle branch block can be really lethal, guys, and it can contribute to very substantial pulmonary edema. Now, to reinforce the facts that I've just explained to you, we will look at one more ECG and evaluate the findings of left bundle branch block. First and the foremost, I'll focus on the heart rate in this case. So you definitely can count approximately 3 large squares present here. So therefore the heart rate of this person would be 300 divided by 3. That would be 100 per minute. And now we will focus on the axis part. When it comes to the axis, you need to look at the data in lead number 1 and AVF from the vector perspective. Lead number 1, R wave is much bigger as compared to S, so the vector in lead number 1 is turning out to be positive. However, when you scroll through AVF, you will notice that AVF, the predominant vector, is the negative one. I mean, if I subtract the number of small squares of R from that of S, the vector is turning out to be negative. So let me just plot this before you. Though in the actual exam, they will obviously not give you the flexibility of drawing anything. So you will have to do this mentally, and therefore I'm making you practice here. You can notice that the vector for lead 1 is turning out to be positive. The vector for lead number AVF is turning out to be negative. So when I join them, the quadrant in which it is falling would be referred as left axis deviation. The next thing which is very striking in the ECG of this particular representation is broad QRS complex. And when I say that, lots of guys will say, sir, why can't it be ventricular tachycardia? Well, for VT, the heart rate has to be more than 100, no? And there are multiple other features that we see in ventricular tachycardia as well. So yes, we are having a broad QRS complex globally present all through. And now when you scroll through or scan through the, I would say the chest leads, you will definitely notice a dominant S wave present in this patient. This is the dominant S wave present. And as you move laterally towards V5, V6, especially for V6, you will be able to notice a dominant broad R wave. You can see how broad and dominant the R wave is. And well, what is this, guys, that I am gonna now highlight before you? Then this scooped out part, no, this scooped out part, this is the ST segment depression which is present. I said no, whatever is going to be the positive vector in a particular lead, the ST segment in bundle branch block will always go the other way around. So you are noticing a S coming up here that I've shown in green, followed by a ST segment depression presented. This is the ST segment per se that I've just highlighted in a scooped out pattern. You can see the red is representing the R, the S is represented in a downswing, and then the ST segment has been highlighted in this case. I've already sensitized you to the fact and would like to repeat this fact that the only ECG where you can be having ST depression written and ST elevation also, which can be highlighted in a different way, right? It's merging with the T wave anyway. So ST elevation and ST depression both are present in the same ECG. And even if you forget about this, I have shown this ECG mainly to highlight that that M pattern or rabbit ear appearance may not be very distinctive. Though you might be noticing this rabbit ear, which is relatively asymmetrical, because one ear of the rabbit is very big and one ear of the rabbit is very small in some of the leads, definitely. But I wanted to show you this ECG mainly to be mentally prepared for the fact that lots of time the characteristic rabbit ear pattern may not be present, and still you should be able to crack it on the main dominant features that I've highlighted, which is gonna be dominant S and broad 1 in V1, V2 with respect to dominant R in V5, V6. The mnemonic William will definitely help you with it. As I said, acute myocardial infarction can be having a new onset left bundle branch block. So we need to understand, is it a pre-existing one or is it a new one? So we have this special criteria which are called as Sagar-Bosa criteria. Now you don't need to go through the details of these criteria, but I just want you to be aware of the fact that how is it that in the casualty lots of time a person might be having ECG findings like the one that I've shown and your consultant is saying it is MI, because obviously left bundle branch block is a presentation of MI, so your consultant is using these criteria. As I'm going to highlight, I mean, why are these criteria, Sagar-Bosa criteria, used? They are used for detecting MI in the setting of a left bundle branch block. We basically want to differentiate whether it was a pre-existing one or whether it is a new one. So let's make a list of causes of left bundle branch block now. The mnemonic or the shortcut that I can request you to remember at the moment can be A2, S2 and D2. So let me just summarize. A would be standing for valvular aortic stenosis and anterior wall MI. Obviously anterior wall MI is where the discussion started from. H2 would stand for hypertension as well as hyperkalemia. Please remember that fact. In a MCQ hyperkalemia, though I have discussed ECG findings of hypo and hyperkalemia separately, hyperkalemia can contribute to ECG findings of I would say left bundle branch block. And D2 would stand for digoxin toxicity. I'm just writing the word alphabet T here, digoxin toxicity, and dilated cardiomyopathy can also be having this manifestation. So these are some of the important causes which you need to remember over and above the fact that left bundle branch block, how can you identify it on a ECG? The characteristic rabbit ear appearance will always be a bonus for you. Now I'm going to describe for you what are the important causes of right bundle branch block, and we'll also have a line diagram highlighting what is going wrong here. This is left fascicle, this is right fascicle. Septal activation occurs like this and is responsible for the Q wave. In a person having right bundle branch block, this right fascicle is damaged. So the current will take more time to go across this area. Intramyocyte conduction will again come up. So even broad QRS can be anticipated here. You see, the problem in this particular chap would be, you can even pick it up from auscultation. From auscultation, I've highlighted, though this is discussed in heart sounds, in these patients, when you look at first heart sound, current will go to the left side. So mitral valve will close on time, but right side information will be delayed. So tricuspid valve will be shifted a little laterally. I have explained to you widespread first heart sound is a feature that can be seen with right bundle branch block. Let's do this once again. Left side current will flow normally, so aortic valve will close on time. You can see current going to left side, no problems. But on the right side, because there is a wastage of time, so P2 will again be shifted. So this would be contributing to wide split second heart sound. This is a revision for you guys. I've taught you narrow split S1, narrow split S2 for left bundle branch block, and wide split S1, wide split S2 for right bundle branch block. Now, once this is going to occur in a patient, one of the predominant findings that will be coming, especially in lead number V1, V2, will be based on the fact that there is not a simultaneous but a sequential activation of the ventricles. So we usually get this pattern. Again, looks like rabbit ears only, but is also written as RSR. You see, in fact, these two R's are representing the two different activations of the ventricle. What I mean by different is that ideally the R of left and right ventricular activation is merged together. In you and me, left ventricle, right ventricle, both will be depolarized at the same time, so the current is merged together, so we have a single R wave. But in this case, the two different R waves are representing a sequential activation of the ventricles. Anything that goes up is R, anything that comes down is S. And obviously the different size, why one is written small, why one is written relatively bigger, is because you see right ventricle will be having less muscle as compared to left. So per se there can be a disparity in the height of the R versus R, as I will show you in the ECG also. Like if you look at lead number V1 here, you will notice that the right got activated and the left also got activated. So there's definitely a disparity in the rabbit ears here. This what I've highlighted is commonly written either as RSR, or you can just call it like this looks like slightly like alphabet M only, no? The only thing is that the top of this alphabet M is not of the same size, which is of the because of the different muscle mass. So one of the very good ways to actually identify a right bundle branch block in a patient. So though we'll go by the norms here, if we can calculate the heart rate, we will now calculate the axis also. I'll go a little faster since we have talked about the axis part already. I've just plotted 1 and AVF. If you look at lead 1, the vector is definitely positive. If you look at AVF, you will notice the fact that this is R and then there's a relatively shortish S. So I'll definitely try to evaluate it here. And in lead number 1, you will notice that the height of the R is approximately 4 to 5. S is also going to be 4 to 5. So I'll just putting a 0 here to say, or I can say it is turning out to be almost equal. So if I plot the data, guys, it might turn out to be a normal axis also. That's definitely a possibility if it's a right bundle branch block, which could be physiologically present. But that RSR pattern will still do the trick for me. So I'm not relying only on left axis deviation versus the right axis deviation in the patient. And one of the highlights of right bundle branch block would be that once you start evaluating, no, the RSR pattern in lead number V1, that would be very easy for you to identify overall. And another feature that can be seen in lead number V5, V6 of these patients would be a dominant S wave and a broad one also. This is a broad S wave. Now, why that is important, the dominant S at the moment, because earlier I was teaching you dominant S in V1, V2, no, that was for left bundle branch block. But now I'm gonna teach you dominant S with V5, V6 for a right bundle branch block. And initially, this might cause a bit of problems for you to remember, but as I will make a table before you, things will become relatively simplified. Let's make a list of causes of right bundle branch block, and then we will compare the ECG findings of the two, the predominant ones that can be worked out in a under 1 minute question. Apart from physiological, which is very obvious, and I don't think so the examiner would love to ask it, they would definitely love to put in conditions like pulmonary embolism, because that involves the right hand side, the pulmonary embolism, the right ventricle gets grossly dilated, and therefore the firing of the right ventricle is anyway delayed. So right ventricular hypertrophy for pulmonary embolism, he can write the word acute cor pulmonale, or he can write the word plain cor pulmonale. I've already sensitized you to the fact that plain cor pulmonale would be COPD and acute cor pulmonale is pulmonary embolism. So do keep a watch for those terms. And then could be obviously ischemic heart disease, then can be rheumatic heart disease, long-term rheumatic etiology. If somebody is having mitral stenosis, then back pressure changes can involve the right side of the heart also. There could be pulmonary artery hypertension developing in the patient. So these are some of the etiologies for right bundle branch block, where especially I want you to remember terms like COPD written, or maybe massive pulmonary embolism written. That should definitely alert you to the fact that the right side of the heart is involved. Now I will be comparing the important findings in the MCQ of left bundle branch block versus that of right bundle branch block. So you can just do this activity with me for lead number V1, V2, lead number V5, V6, because that is where the changes would be. For V1, V2, as I highlighted, there will always be a dominant S wave. But when it comes to right bundle branch block, where do you get dominant S wave? V5, V6. How to remember it? V1, V2. If it's gonna be dominant S wave, you can remember either of the two, no? And then you can just reverse the findings. For when it comes to V5, V6, there would be a tall and a broad R wave, and lots of time that rabbit ear appearance if present will definitely help you. Along with that, there will be absent Q waves in the ECG. There would be discordant ST segment changes. There would be nothing like absent Q wave with respect to the person who's having a right bundle branch block. And V1, V2 will be having this classical RSR pattern, or is also referred as M pattern. I mean, whether you call it M or not, that's optional for you. And that can help you remember the facts. In fact, the mnemonic that is used and is available all over the internet is William and Marrow. So the words that you can be using are first alphabet and the last alphabet, no, for William and Marrow per se. So left bundle branch block, the first lead, that would be, as you can see, going down. W is going down. So that is how you remember a dominant S with that stuttering. That is the every time these rabbit ears are coming. No, what are they signifying? They signify what was actually told to you in the starting of this lecture. That is gonna be a sequential activation. So if you get these facts right, especially if I usually find most guys are able to relate to this topic very easily with help of the mnemonic itself. And the reason why I've discussed this topic is mainly for the causes and the lethality with respect to left bundle branch block, and also to make you remember the fact that whenever you read the word new onset left bundle branch block, because even if he does not give you the ECG in the exam, if he's just saying the word new onset bundle branch block, then watch for myocardial infarction diagnosis should always be kept, because if it is new onset, then obviously the left fascicle has been damaged. So these are the details that I would like you to remember for this topic. Thank you so much for hearing me out, and keep hammering, keep learning, guys. You'll do great.